Okay, let's unpack this. Have you ever stopped to truly consider what happens inside your body when a bone breaks? It's far more intricate and honestly more surprising than just a simple snap. We often think of it as, a single event, but really it kicks off this whole biological drama.
It absolutely does. Today, we're taking a deep dive into the fascinating world of musculoskeletal trauma, specifically fractures. Our source material really lays out that critical journey from the moment of injury through the complex process of recovery, and it reveals some truly astonishing and sometimes pretty startling insights into how the body heals and how we intervene. By the end of this deep dive, you'll have a really comprehensive, well-informed understanding of what seems like a common injury, but is actually anything but simple.
Okay, so let's start right at the beginning then. When we talk about a broken bone, what are we actually describing? Fundamentally, what is a fracture?
Well, fundamentally, a fracture is just a break or a disruption in the continuous structure of a bone. Think of it like a crack or maybe even a full separation that interrupts that strong, seamless line of the bone.
And I imagine not all breaks are created equal, right? I mean, a tiny hairline crack must be totally different from, well, a bone sticking out.
You're exactly right. We classify them pretty quickly because those distinctions tell us so much about the immediate severity and what needs to happen next. We talk about things like incomplete closed or non-displaced fractures. That's where the bone might be cracked, but it's still mostly aligned, or the skin is still intact. Then you have the complete open or displaced fractures. These mean the bone is fully separated, or in the case of an open fracture, it's actually pierced through the skin. And those open fractures, they're particularly concerning because of the infection risk.
Right. So once that continuity is disrupted, it's not just a matter of waiting around. The body, it's incredible. It has its own built-in repair crew. It's like this sophisticated construction project just kicks off instantly. Can you walk us through that amazing process?
Yeah, what's truly fascinating here is how the body orchestrates this incredibly complex repair. It's not just like gluing pieces back together. It's more like a sophisticated biological symphony. There are 5 distinct stages. Imagine a tightly choreographed dance almost. Within the first, say, 48 to 72 hours, the first stage is hematoma formation. This is essentially just a blood clot forming right at the fracture site. It serves as the body's immediate internal bandage.
A natural first responder almost, sealing off the area.
Precisely. That hematoma then becomes the foundation for stage 2, which lasts roughly from 3 days up to about 2 weeks. This is when that blood clot starts to transform into what we call granulation tissue, which is essentially new, delicate connective tissue. It's kind of the initial scaffolding forming a soft bridge across the break.
Okay, so not bone yet, but the early architecture is starting to take shape.
Exactly. Then by about 3 to 6 weeks, we enter stage 3, callus formation. This is where fibrous tissue and cartilage begin to form a soft callus around the fracture site. It's often described as the beginning of a non-bony union. It offers some early stability to the site. From there, in stage 4, that soft callus gets gradually replaced by a harder, stronger substance as it transforms into actual bone. And finally, stage 5 is the consolidation and remodeling phase. This is the longest stage. It can potentially take anywhere from, say, 4 or 6 weeks up to a full year. This is where the bone strengthens, reshapes itself, and eventually regains much of its original form and strength. It's an absolutely remarkable display of self-repair.
It sounds like a perfect plan, almost too good to be true. But we know biology isn't always so straightforward, right? This is where it gets really interesting and maybe a little bit alarming too. A broken bone isn't just about the bone itself. It can sometimes trigger this cascade of systemic issues. What are some of those immediate, really critical dangers?
Well, one of the most obvious immediate dangers, especially if you have an open fracture or require surgery, is infection. This can range from just a superficial skin infection to deeper wound abscesses, and it can potentially introduce severe risks like clostridia or even tetanus if the wound is contaminated. But beyond just the local infection, the body's systemic response to the trauma can lead to some pretty alarming complications.
And what kind of systemic complications are we talking about? I know blood clots are often a concern with injuries.
They are, definitely. Venous thromboembolism, or VTE, that can show up as a deep vein thrombosis or a pulmonary embolism. That's a significant risk. But an even more acute and frankly dangerous complication after certain fractures, particularly hip or pelvis injuries, is fat embolism syndrome, or FES. This is when tiny fat globules released from the yellow bone marrow after the break get into the bloodstream and clog small blood vessels. It can affect organs far from the actual injury site, primarily the lungs and the brain. It tends to happen more often in younger men, maybe 20, 40, and also older adults around 70, 80.
Wow, so the actual components of the bone marrow can become a systemic threat. That's quite something. What are the warning signs? How would you know FES is happening?
The symptoms are quite distinctive and usually appear pretty suddenly. A noticeable change in mental status is a big one. Confusion, anxiety, also difficulty breathing, a rapid heart rate and breathing rate, maybe a fever, coughing up bloody sputum, and a very specific rash called petechiae. These are tiny, pinpoint red spots on the skin, often appearing on the trunk. It's a definite medical emergency, requires immediate attention.
And then there's something called compartment syndrome. That just sounds incredibly severe and like you're racing against the clock.
It truly is. Acute Compartment Syndrome, ACS, is a serious medical emergency. It happens when pressure builds up inside these enclosed muscle compartments, most commonly in the lower leg or the forearm. Imagine the muscles and nerves just being squeezed too tightly within their fascial sheath, which doesn't stretch. This pressure drastically reduces blood flow to the nerves, the muscles, the blood vessels in that compartment. And what's absolutely critical to understand is that irreversible damage, neurovascular and muscle damage, can happen in as little as 4 to 6 hours if that pressure isn't relieved. It can be caused by swelling after the injury itself, or even sometimes by a cast or a tight dressing that's put on too snugly.
So time is absolutely crucial. What are the telltale signs, the things a medical professional or even the injured person might notice?
We often talk about the 6PS. It's a good mnemonic. Unrelenting pain that isn't relieved by pain meds is number one. Then a palpable sense of pressure in the limb, paralysis or weakness setting in, paresthesia that's numbness or painful tingling, pallor, so the skin looks pale, and finally, a diminished or even pulse absent in the affected limb. Honestly, if you're ever in a situation with a severe injury, knowing these critical signs can genuinely be life-saving. The body's response to trauma really can be a race against time.
Okay, so those are the immediate crises. But what about the long haul? What happens when, bone healing just doesn't go as planned, even months later?
Right, long term, so beyond that initial 6-month window, we can run into complications like avascular necrosis or AVN. This is essentially the death of bone tissue because it loses its blood supply. It's actually quite common in certain types of hip fractures, especially if the bone pieces were badly displaced or if hardware was used in the surgery. Also, patients with a history of using prednisone are more at risk. Then there's just delayed bone healing, or in more severe cases, non-union. That just means the fracture hasn't healed within 6 months. This is more common in older adults, and it can lead to persistent chronic pain and significant immobility.
And are there things that can be done to sort of kickstart the healing in those difficult cases?
Yes, absolutely. We have several strategies we can try. Things like electrical bone stimulation to try and encourage growth. Bone grafting is another option where healthy bone tissue is transplanted to the site. And even low-intensity pulsed ultrasound that's known as exogen therapy, which can help stimulate the body's natural healing process.
And then there's this condition that sounds almost unreal. Complex regional pain syndrome, or CRPS. You said, imagine your body's pain system going completely haywire after an injury. It's not just lingering pain. It's like a whole different debilitating beast.
It's an incredibly challenging condition, really. CRPS is a poorly understood dysfunction of both the central and peripheral nervous systems. It leads to this severe chronic pain that often feels completely disproportionate to the original injury. Patients experience these abnormalities of the autonomic nervous system, so changes in skin color or temperature or sensitivity in the affected limb. They might also have motor symptoms like muscle weakness or spasms and this altered sensory perception, often described as an intense burning pain. It's a condition that truly highlights the really complex and sometimes quite unpredictable interplay between the physical body and our nervous system.
So when someone comes into, say, an emergency room with a suspected fracture, beyond the immediate life-saving checks, the ABCs, what's the initial assessment look like? What are they looking for?
Right, beyond the critical airway, breathing, circulation checks, they'll look for specific red flags. For instance, with a pelvic fracture, they'd immediately check the urine for blood. That suggests possible internal organ damage. For a hip fracture, severe groin pain is a really key symptom. More broadly, though, they're assessing for any observable changes in the alignment, or maybe the length of the limb, any obvious deformity in the bone's shape. Intense pain upon even slight movement is a big clue, and also a decreased range of motion at the nearby joint.
Okay. And once they have that initial picture, how do they actually confirm the fracture or look for other damage?
That's where diagnostic tools come in. X-rays are usually the first stop, just to visualize the bone itself. CT scans give much more detailed cross-sectional views, which can be really helpful for complex fractures. And MRI scans are excellent for looking at soft tissue damage around the fracture. Things like ligaments, tendons, or muscles. Blood tests are important too. Hematocrit and hemoglobin levels can show if there's been significant bleeding. And an elevated ESR, that's the erythrocyte sedimentation rate, that might point towards significant inflammation or soft tissue damage.
Okay, so what are the immediate, like, on-the-spot emergency management steps if someone likely has a fracture? You mentioned stabilizing the person first, right? Not just the bone.
Absolutely. Those immediate steps are paramount for stabilizing the person as a whole. First, always that crucial assessment of airway, breathing, and circulation. Then, you'd carefully remove any clothing around the injured site to get a good look. But, and this is important, do not remove shoes if the injury is in the lower leg or foot. Taking the shoe off can cause more harm sometimes. Always remove jewelry from the affected limb because swelling is pretty much guaranteed. You need to control any bleeding, keep the patient warm, try to keep them lying flat if possible, perform regular CSM checks, that's circulation, sensation, and movement in the limb below the injury. And then, immobilize the injured extremity as best you can and cover any open wounds with a sterile dressing.
Right. Once they're stable, the next big step is getting that bone back into proper alignment, isn't it?
That's right. That's called fracture reduction. It's just the realignment of the bones to help them heal properly. This can be done either as a closed reduction, which involves manipulating the bone from the outside, no surgery needed, or an open reduction, which does require surgery to directly access and realign the bone pieces. That's often followed by internal fixation, like putting in plates or screws. But once it's reduced, the bone absolutely needs to be immobilized to allow that healing process we talked about to happen undisturbed.
It's actually amazing how many different ways there are just to hold a bone perfectly still while it heals. Each must have its own, pros and cons.
Indeed. Immobilization techniques vary quite a bit. You've got simple bandages and splints for less severe injuries. Then there are casts. When we talk about casts, the main types you see are plaster and fiberglass. Plaster casts are heavier, they take longer to dry, sometimes 24 to 72 hours, and they actually give off heat as they harden. You have to handle them with your palms while they're wet. Fiberglass casts dry much faster, maybe 10-15 minutes. They're lighter and generally more common today, though plaster can sometimes bear more weight, so it still has its uses. But regardless of the type, casts aren't without risks. They can lead to infection under the cast, circulation problems, nerve damage, or just the general complications that come with being immobile.
And then there's traction. That seems like a really traditional method, but I guess it still plays a vital role.
Oh, absolutely. Traction is basically applying a sustained pulling force to the body part. It serves several purposes. It can help reduce a fracture, maintain alignment, give the fracture site some rest, and importantly, decrease painful muscle spasms, which are common. There are two main types. Skin traction, like using a Velcro boot, uses lighter weights, maybe 5-10 pounds, applied externally to the skin. It's mainly for reducing muscle spasms. Then there's skeletal traction. This involves pins, wires, or tongs being surgically implanted directly into the bone itself. This allows for much heavier weights, maybe 15-30 pounds. A crucial safety point here. The weights must always hang freely. They should never rest on the floor or bed. And meticulous pin care around where those pins enter the skin is vital to prevent infection. And beyond traction, of course, we also have internal fixation devices, plates, screws, rods put in during surgery, and external fixation devices too. Those are the metal frames you sometimes see on the outside of a limb, connected by pins going into the bone. They provide really rigid stability.
Let's talk about some specific injuries now, starting with one that unfortunately affects a lot of people, particularly as they get older.
You're probably thinking of hip fractures. And you're right, they are the most common fracture type in older adults. And sadly, they do carry a pretty high mortality rate. Pain management is absolutely crucial for these patients, both before and after surgery. Postoperatively, a really significant concern in older adults is the risk of developing delirium. So maintaining their safety, keeping them oriented, monitoring cognitive function, that's a top priority. Really, holistic care, including getting them moving early and good nutritional support, is vital for these often complex patients.
And what about fractures to the chest and pelvis? Those seem inherently dangerous just because of what they're protecting inside.
They definitely are. Fractures of the chest and pelvis carry a high risk for damage to vital internal organs, the lungs, the heart, major blood vessels, and also a high risk of significant internal bleeding. That's why reiterating that assessment of airway, breathing, and circulation isn't just a routine check. It's the absolute critical first step in these specific cases.
Then there are spinal compression fractures. What usually causes those, and how are they often treated these days?
Yeah, compression fractures of the spine are frequently caused by weakened bones. Often it's due to osteoporosis, but sometimes metastatic bone cancer can weaken the vertebrae too. They can cause severe pain, especially with movement. The good news is they can often be treated with these minimally invasive procedures called vertebroplasty or kyphoplasty. These basically involve injecting a type of medical cement into the fractured vertebra to stabilize it. This often provides really rapid pain relief, and patients can sometimes even go home just hours after the procedure. It's quite effective.
Okay, now for a very different, and I imagine quite profound, kind of injury and recovery journey, amputations.
Yes, amputations. They can be either surgical, usually elective, often due to conditions like severe peripheral vascular disease where blood flow is compromised, or they can be traumatic, resulting from accidents. Upper arm injuries are actually particularly common in traumatic amputations. Post-operatively, there are several potential complications to watch for. Hemorrhage, infection, something called a neuroma. A neuroma is like a tangled growth of nerve tissue at the end of the severed nerve, and it can be quite painful. And also flexion contractures where a joint gets stuck in a bent position.
But one of the most intriguing and often misunderstood complications has to be phantom limb pain. It just sounds so counterintuitive. How can you feel pain in a part of your body that literally isn't there anymore?
It's truly where that mind-body connection becomes incredibly striking, isn't it? Phantom limb pain, or PLP, is a frequent and very real complication. The patient experiences pain that feels like it's coming from the site of the removed body part. It often starts fairly soon after surgery. The pain itself is often described as an intense burning or a crushing sensation, maybe cramping. Some patients even feel that the absent limb is still there, but may be in a distorted or uncomfortable position.
And if it's not physical pain in the usual sense, how is it managed? You mentioned opioids might not be the best approach.
You've hit on a really crucial point there. It is absolutely vital to recognize that this pain is real to the patient. It significantly impacts their quality of life. And you're right, while opioids are often not as effective for phantom limb pain, other types of medications are used. Things like beta blockers, propranolol is one. Anti-epileptic drugs like gabapentin can be helpful. Antispasmodics like baclofen. Sometimes even IV infusions of a hormone called calcitonin are tried. It seems the brain can still register and generate these pain signals from a limb that's no longer physically present. It profoundly challenges our traditional understanding of pain itself.
After an amputation, getting mobile again must be an immediate and ongoing challenge. How is that typically addressed?
Yeah, early and consistent range of motion exercises are critical, especially to prevent those flexion contractures of the hip and knee in leg amputations. A trapeze bar fitted over the bed can significantly help the patient move themselves around. A firm mattress provides better support too. Patients are often encouraged to lie in a prone position, so on their stomach for periods every 3 to 4 hours. That helps prevent hip flexion contractures. There's some ongoing discussion about elevating a lower leg residual limb. Generally, it's only recommended for the first 24 to 48 hours right after surgery because prolonged elevation can actually contribute to contractures.
And eventually, the goal for many is getting a prosthesis, right?
Yeah.
How does that transition usually work?
Yes, for many people, a prosthesis is the ultimate goal to regain function. Immediately after surgery, various devices might be used to help shape and shrink the residual limb. These could be rigid or removable dressings, sometimes plastic inflatable devices, or just elastic bandages that are reapplied every 4-6 hours. Some patients might get a temporary prosthesis relatively soon after surgery, but the fitting of the permanent prosthesis usually happens after the residual limb has fully healed and stabilized its shape. This ensures the best possible fit and function long term.
Okay, switching gears a bit to another incredibly common issue, this time in the upper extremity, that affects loads of people in their daily lives. Carpal tunnel syndrome. Many people know the name, but what exactly is it? What causes it?
Right, carpal tunnel syndrome. It's what we call an entrapment neuropathy. That just means a nerve is getting compressed or trapped. Specifically, it's the median nerve right at the wrist that gets squeezed within that narrow passageway called the carpal tunnel. It's frequently caused by repetitive hand movements, the kind you see in certain jobs. But it can also be linked to underlying conditions like rheumatoid arthritis or diabetes. Even pregnancy can trigger it sometimes, usually due to fluid retention.
And what are the classic symptoms? How would someone know if they might have it? What should they look out for?
The symptoms typically follow the path of that median nerve. So you get pain, numbness, and paresthesia. That's the painful tingling or pins and needles feeling. Specifically in the thumb, index finger, and the middle finger. Sometimes the ring finger too, partially. There might also be weakness in the hand, like difficulty gripping things. Diagnosis often involves a simple clinical test called Phelan's maneuver. You basically press the backs of your hands together with your wrists bent downwards for about a minute. If doing that reproduces your symptoms, the pain, the tingling, it's a pretty strong indicator of carpal tunnel.
And what are the treatment options available, from maybe simple things to more involved procedures?
Treatment options really range along a spectrum. Conservative approaches come first. Things like wearing wrist splints, especially at night, to keep the wrist in a neutral position. Avoiding those repetitive wrist flexion movements. NSAIDs, like ibuprofen, can help with pain and inflammation. Sometimes cortisone injections directly into the carpal tunnel can provide relief. If symptoms persist and are severe, then surgery becomes an option. This can be done as an open procedure, or endoscopically basically, cutting the ligament that's pressing on the nerve to release the pressure. Post-operative care involves neurovascular checks of the hand, pain management, usually wearing a hand splint for a while, and importantly, limiting hand use for about 4 to 6 weeks to allow healing. It's worth noting, though, that even after treatment, the condition can unfortunately recur for some people.
Okay, beyond these specific examples, what are some other common musculoskeletal injuries people might encounter? Anything else we should touch on briefly?
Well, we often see tendon ruptures. A common one is the Achilles tendon rupture, down at the heel. You see this quite a bit in adults who participate in strenuous sports. That sudden pop. Severe damage usually needs surgical repair. That's typically followed by immobilizing the leg in a cast for maybe 6 to 8 weeks. Sometimes a tendon transplant is even needed if the damage is really extensive. Then there are rotator cuff injuries in the shoulder. These cause significant shoulder pain and often difficulty lifting the arm out to the side or rotating it. There's a diagnostic test called the drop arm test, where the patient can't smoothly lower their arm from an elevated position that can indicate a tear. Treatment can range from conservative things like NSAIDs, physical therapy, ice or heat, to surgical repair, especially for complete tears of the tendons.
So, after covering all this ground, from the tiny details of bone healing to these major injuries and complex treatments, what are the big overarching principles for really supporting a patient through their recovery? Because, as you said, it's not just about setting the bone, it's about supporting the entire person through what can be a really challenging and often quite long process.
You're absolutely right. It's precisely about that holistic approach. Effective pain management is obviously foundational. This includes not just the reduction and immobilization of the fracture itself, but also carefully assessing pain levels on an ongoing basis, using appropriate drug therapy, both opioid and non-opioid medications, and importantly, integrating complementary therapies. Things like ice, heat, elevation, massage, even distraction techniques or music therapy can really help. Preventing infection is also paramount. This requires strict aseptic technique during wound care or pin care, vigilant assessment for any local signs of inflammation or purulent drainage, monitoring for systemic infections too, like pneumonia or UTIs, which can happen when people are laid up, and using broad-spectrum antibiotics appropriately when an infection is suspected or confirmed.
And mobility obviously is a huge piece of getting back to normal life.
Huge. Promoting mobility involves constantly assessing for any complications related to being immobile, like skin breakdown or blood clots, and crucially, teaching the correct and safe use of assistive devices, crutches, walkers, canes. A key detail that's often missed. A cane should always be placed on the unaffected side for maximum stability and support, not the injured side. And finally, nutritional support. It's vital but often underestimated for healing. A diet that's high in protein, calories, and calcium is really important. Supplemental vitamins, especially B and C, can help. Sometimes frequent small feedings are easier to manage. Ensuring enough iron intake is good too. All these interventions taken together, they really contribute to a truly holistic recovery journey.
Wow. What an incredible journey the body takes, isn't it? From just a simple disruption in a bone's continuity to this really complex multi-stage healing process and all the potential pitfalls and, frankly, profound complications that can happen along the way. It truly highlights the body's remarkable resilience, but also the critical importance of timely, informed, and really holistic care.
It really does. And considering that intricate journey a body undergoes after trauma, from the molecular dance of bone healing right through to the perplexing neurological experience of phantom limb pain, it really raises an important question, doesn't it? How much of our perception of self is truly physical, and how much is woven into this complex, often unpredictable tapestry of our nervous system? We hope this deep dive encourages you, the listener, to maybe reflect on the incredible capabilities of the human body and the profound complexities of healing that unfold within us, sometimes without us even noticing.